Hi, I'm Deb Miller. I'm the director of the Public Management Center at the University of Kansas. I'm pleased to introduce this webinar series. We've missed engaging with you live and in person. Who knew something so common could now feel so precious and valued? Though not live and in person, we hope these webinars will provide you with a convenient outlet to continue learning, and in this now daily virtual way, connecting with other public sector professionals. Because they are pre-recorded, you can view the webinars as your schedule allows, share them with others if you choose, and listen to key points more than once. Each of our speakers has offered to make themselves available to answer your questions. If you have questions, please leave them in the chat or in the comments below. We will either connect you with the presenter or respond to you with an answer. Here at the PMC, we believe that public service lies at the heart of democracy. During these strange, uncertain times, you are doing democracy in ways you never imagined and finding workarounds you never expected to need. We salute you and hope that in some small way, we can support and assist you in your work.
Dr. Lee Norman is the Secretary of the Kansas Department of Health and Environment, appointed by Governor Laura Kelly. Norman received his medical degree from the University of Minnesota, did his residency in family medicine in Texas, and his aerospace medicine training in the United States Air Force at Brooks Air Force Base in San Antonio. After serving in the Air Force as a family physician, flight surgeon, and combat medicine instructor, he practiced medicine in Seattle for 20 years. Also serving as clinical associate professor at the University of Washington School of Medicine. Dr. Norman has served as a chief medical officer for over 26 years, most recently at the University of Kansas Health System, and before that at the Swedish Health System in Seattle, beginning in 1991. He currently is clinical assistant professor at the University of Kansas School of Medicine. Norman was on the governing board and the chairman of the Puget Sound Blood and Tissue Transplant Center in Seattle, and more recently on the governing board of Heart to Heart International, a humanitarian organization based in Lenexa, Kansas. He currently serves on the Defense Health Board, which advises the U.S. Secretary of Defense on health matters, and the Oversight Board of the Kansas Intelligence Fusion Center. In his military role, Norman is a colonel in the Kansas Army National Guard, stationed at Joint Forces Headquarters in Topeka, Kansas. Colonel Norman, as a state surgeon of Kansas, guides medical troop sustainment and training, health services support, force health protection, biosecurity, and serves as advisor and liaison to the Kansas Department of Emergency Management and Homeland Security. He is a biothreat and pandemic illness advisor to the Kansas Intelligence Fusion Center. In 2018, he returned from a Middle East U.S. Army deployment where he was the 35th Infantry Division Surgeon. In this role, he was a senior medical commander over 12,000 U.S. soldiers, encompassing 3 named operations: Freedom Sentinel, Spartan Shield, and Inherent Resolve. Dr. Norman has 2 master's degrees, one in health planning and systems analysis from the University of California, Davis School of Medicine, and an executive MBA degree from the University of Washington Graduate School of Business. He has 2 grown children, 2 grandsons, and an energetic, one-eyed Australian Shepherd named Blue Dog. Dr. Norman is a Midwesterner, born and raised in Iowa. His hobbies and interests include reading, cooking, canning and pickling, technical mountain climbing, and collecting Eskimo art, including native carvings, masks, etchings, and baskets.
Hi, my name is Dr. Lee Norman. I'm the Secretary of the Kansas Department of Health and Environment. And what I wanted to do today was to give you a brief presentation on COVID-19, where we are and what's ahead. What I want to do today briefly is to relate what kind of trends are occurring nationwide and the impact on Kansas, how we're approaching the pandemic here, what's happened so far, how we've organized the effort, and then finally forecast what's ahead, including vaccine development. Quick reminder, pandemics are nothing to trifle with, and that's why we really have to be continuing to work hard on that. Humanity has but 3 great enemies: fever, famine, and war. And of these, by far the greatest is fever. And I think that's testimony to the fact that a global infection, a pandemic, can have such catastrophic impacts. And we're seeing that in our country. And And as a reminder, I think that pandemics are not new, been around for hundreds of years. We've learned from them and want to continue to pay attention to those lessons. It's also a threat to national security. And this is a 2017 article in Time magazine. I think that some of us have been watching the pandemic preparedness efforts for a long time and have been uneasy. Many of us were surprised, actually, that this newest pandemic wasn't an influenza. Mostly we worry about avian influenza jumping over into humans. This coronavirus was a bit of a surprise, but not a complete surprise. And by that, I mean, we have experiences that have informed this. My own personal ones are a couple things. One is that was from my deployment in 2017 and 2018 to the Middle East. And I'm recalling an H1N1 2009 is being used as a framework for our vaccine distribution effort that we will be doing with the COVID-19 vaccine. It's also very humbling to remember the Middle East deployment. I saw firsthand MERS-CoV, the Middle East Respiratory Syndrome, which is a coronavirus, and a reminder that that didn't peak out until the 4th year of the infection. That's, again, mostly in the Arabian Peninsula and South Korea, different coronavirus than what we have here with COVID-19, but it is still going on. There's a highly lethal disease, so we really need to continue to push on a vaccine because they have not had a vaccine for this particular MERS-CoV yet. Back home in Kansas, we were not in a particularly great place in the state of Kansas, quite honestly, when this COVID-19 arrived. Over the last 30 years, we've seen a continuous decline. This is America's health rankings. You can see that steady decline over 30 years. It relates quite a bit to the amount of investment and other things we've done. This is based on nutrition, obesity, smoking habits, sexually transmitted diseases, and the like. And what it pointed out to us was a couple things. Underinvestment in public health. Kansas, out of general funds, we only get $60 per Kansan per year, which is in the lowest third of the United States in terms of public health investment. It's shown that that's a problem in many different aspects of public health, not the least of which is our antiquated, outdated public health and environment laboratory, because we are needing to forever increase our testing capacity, and this has been a rate limiting factor. Along with this, I call this phase 0 or stability operations. We were built for not having a major pandemic or other kind of emergency, certainly not one that lasts as long as this is going to last. So we had very little surge capacity in the state. We had supplies in storehouses and things like that, but those went through very fast. The local health departments, we have 105 counties and 100 health departments, and they similarly have not been funded to the degree necessary for managing the pandemic. So that's the groundwork, and then COVID-19 arrives. Immediate response. At the federal level, there was intense competition for PPE and testing platforms and supplies. We were finding our state competing with other states and the federal government, including FEMA. A lot of those supplies were being diverted to both coasts where there was vast numbers of cases. We had not as many cases numerically, but we certainly had a per capita case rate similar to California. This has resulted in long testing turnaround times because, again, the federal government has sequestered away a lot of that testing capacity and redistributed it. I think we did pretty well at the local level. We set up incident command early, county and state declaration of emergency, which helped to then drive the opening of the State Emergency Operations Center and the Kansas Division of Emergency Management. We work very closely hand in glove with them. And then finally, gradually capacity building despite constrained resources, especially around protective equipment and testing, but we also, through KDHE, send out meals and PPE to nursing homes and the like. I'm not going to spend a ton of time with this, but this is how we organized our lines of effort. It's pretty descriptive of the 8 large buckets, you might say, of the things that we concern ourselves with. Epidemiology, disease tracking, community testing has, of course, been the top of everybody's list of to-dos and to improve. Media and community education and engagement. There's been so many countervailing messages and quite honestly, through social media especially, just things that are plain old false. And it's been a constant battle to keep great quality information in front of people. Isolation and quarantine, how do you educate and inform people when they are either exposed or infected? And then how do you enforce that? Overall, I think we've had a pretty cooperative state, but people are losing their sense of humor about this, quite honestly, and I think it's going to get more and more difficult. Policy and guidelines I'm going to get to in a minute. Community relations, schools, and local health department liaison function. How can we help the locals? And schools, obviously a hot topic now that we're in back with K through 12 education and colleges, universities, community colleges, and the like. And through all this, best practices, it's important that we do research and find out from other places what works best and how do we apply that to the state of Kansas. And there's been some pivotal considerations like, do we buy hydroxychloroquine, that anti-malarial? Is it any good? And that comes out of best practices research, our decision to not buy and stockpile a bunch of that. And finally, line of effort 8 is materials, supplies, and stockpile, a continuous battle to find purveyors of PPE and testing supplies and then to buy and help our hospitals and clinics with that. One of the very important thing, obviously, is finding out who's infected and then who are they exposed to. So the series of events that we go through is not a big secret, but I think it bears mentioning. A series of events is testing. It's important that we test everybody that's symptomatic. And more we're finding ourselves wanting to do to look at asymptomatic people for prevalence studies and to find early on who's infected, who needs to be put into a quarantine arrangement. Data transmission, it's important that wherever the testing is done, it goes to the local health departments and to the state so we know where to increase our efforts, where to double down on the efforts. Case investigation, meaning interviewing the people who are ill or in this case contact tracing who might have been exposed and need to have some special things done regarding quarantine and isolation. There's GPS and Bluetooth assisted technology devices. We have a law in the state of Kansas that disallows us from using GPS notifications of people who have been exposed to somebody, but there's other Bluetooth assisted technologies we're reviewing. The role of third-party administrators, or third-party entities, I guess I'd say, schools and school administration, employers, we work with them to, in a cooperative manner to identify when there's been a known case, how do we locate the people around them to find out if they've been exposed. And most part, employers have been very enthusiastic to help with us. And the reason is, honestly, they are interested in their employees' well-being. That keeps their business functioning and thriving, so it's been good. State and county health officials, authorities, and to order mandatory facility and event closure. This is kind of a tricky one because I, at the state level, and my counterparts at the county level would rather work in a cooperative manner with the city leaders and schools, businesses, et cetera. But we do have the authority to issue mandatory closure orders. It's been used a few times, but fortunately, mostly people are pulling the same direction. I think it's really important for employers to actively listen to their employees. I get emails unsolicited from people, just community citizens, who say they've approached their employers and have fallen on deaf ears. And I think it's really important for employers to listen to employees. And then there's a concern that's been made that I've been made aware of about employer negligence. And I think that that's something that won't happen unless there's a long and sustained turning of a blind eye by employers to the employees, or students for that matter, by administration. I think it's really important to work together. This slide shows early on the key decision points. This goes from about March to end of June or so. And it shows the first cases occurred in the first part of March. The schools closed, and then one incubation period later, stay-at-home order was issued. 2 incubation periods later, peaked out almost on the exact date we predicted that it would. and then a gradual phasing in of the normal activities and a phased in reopening of the state. Slowed it down a little bit because we were starting to plateau, although we were certainly moving the right direction and had one of the most enviable case per capita positions of any state in the country. But through some legislative and attorney general decision making that was done, it changed the things that were mandatory to make them guidance. And as a result of that, plus Memorial Day, the doors opened up to the summertime, and people went to large gatherings and rodeos and rock festivals and party coves, and it's been awful since then, quite honestly, with the number of cases just going up, up, up. So we're not in an enviable position right now as it relates. We're in the top 10 in both the per capita number of cases and the per capita percentage, the percentages of positive tests. We must do better on the things that we know that work. And the things that we know to work, this is a good article in Nature magazine looking at a bunch of different countries, is emergency declarations to bring resources, travel bans, mass gathering limitations, social distancing, quarantine of inbound travelers, working from home, school closures, and event cancellations. It's all stuff we've been talking about. Somewhat successful, but by themselves, not entirely successful. Masks by themselves. But masks bring a terrific amount to this when you put it in with mass gathering limitations, social distancing, et cetera. Also successful are paid sick leave to allow people to stay home when they're ill and not encourage them or incentivize them to come to work sick, and business closures. Now, I think we've learned a lot about business closures in that it is successful in preventing the spread of the virus, but I think we've also learned that it's not really necessary to have complete closures, but rather to modify engineering controls and changes in the things that we do regarding masks and whatnot. And finally, modest impact at best is slow the spread guidelines. In other words, placards, messaging, et cetera. That by itself isn't enough unless the other things are done on here. Remember, we don't have a medication and we don't have a vaccine. When we have those, it'll be a game changer. Let's talk about just a few remaining things. Genetic drift, I want to talk about how the virus is changing a little bit and that discussion within the context of vaccine development. This is a picture out of 1918, Spanish flu, Fort Riley, or Camp Funston, Kansas. It's a reminder that the H1N1 that causes Spanish flu is out there now. It's still circulating, but we don't have the Spanish flu pandemics anymore, and the reason is we have a vaccine for it, which has driven a lot towards herd immunity. This is a very pretty slide. Each one of those little dots, different colors, represents one patient and the virus, and it's genomically typed. In other words, gene typing is almost like a fingerprint in how specific it can be. And these three blue arrows, I think, are important to consider. Those are three kind of families of the related COVID-19 virus. They're a bit genetically different, each from the other. And I think it's going to be fascinating to see when a vaccine comes out, will it cover all three of those? Are there enough similarities between all those three different kinds of virus within the COVID-19 family? Or will each of those require a different strain, like with influenza? We have a quadrivalent vaccine, 2 influenza A, 2 influenza Bs. Brief slide, OWS, that stands for Operation Warp Speed. Some of the Operation Warp Speed vaccine manufacturers will push it directly to the parties on the right. The ancillary supplies and PPE like syringes and Band-Aids and all those things will be accompanying the vaccine when it comes out. And I'm not going to read these to you. You can look at the slide. The top 5 light gray boxes are where the vaccine will be shipped directly by the federal government, and the bottom 5 darker charcoal boxes will be distributed to by us at the state. They will send the vaccine to us. So I guess in summary, this is a tough time that we've been going through now. People are losing sense of humor about this and are getting restless. And I think that one of the things that we have to remember is that This is an illness that probably has affected so far around 5%, maybe slightly more than that, of our Kansans. The salvation is going to come through a vaccine. But until that time, doing the things you can do to modify your risk are critically important. I get more convinced by the day that it's mass gatherings that are really the secret sauce for this virus being successful. We did so much better before we opened up on May 27th and said, let's just go out and have mass gatherings. And of course, we see it all the times in weddings, funerals, concerts, athletic events, and the like. So be very attentive to wearing your mask. There doesn't have to be a mandate to wear a mask. Wear a mask, avoid mass gatherings, socially distance, wash your hands. These things, I know you're tired of hearing about them, but they are really critically important. And thank your public health personnel. I have to tell you, it's been discouraging for me in some regards because our local health departments feel like they're kind of having a battle with their own citizenry. And in reality, my favorite quote about public health, nobody ever thanks you for saving them from a disease they didn't know they were going to get in the first place. I think it's really a great time to reach out to your public health officials, your school officials, nurses, healthcare providers, first responders, and give them a pat on the back, and especially help them by pushing down the numbers with the things that you know you can do, including mask wearing and the like. So this is Lee Norman, Secretary of Kansas Department of Health and Environment, giving you a brief update on COVID-19.